year's World Kidney Day. It's themed Living Well with Kidney Disease and pushes us to go towards patient-centered care for people living with kidney disease. You can go on to the next one. The theme really comes out of what has been happening out there. Everybody, in terms of the non-communicable disease world, is pushing towards patient-centered care, particularly when you look at the big organizations like United Nations. They've been subscribing for the promotion of patient-centered healthcare systems, for empowering patients and giving them access to their own healthcare information, promoting health literacy, and strengthening patient involvement in clinical decision-making with a focus on professional patient communication. So we have to communicate better. We have to engage our patients better in making decisions. The question for us in Botswana is really, what can we do better? What can we improve? If we can go on to the next slide, Doc. There are a few things that have been proposed by the World Kidney Day organization, move us further along patient-centered care for people with kidney disease in particular. One is really to focus on empowering patients to understand their role and to have knowledge and confidence to be able to engage with clinicians and a shared decision-making and support self-management. I think this one summarizes it, because we find that our patients really don't ask too many questions, but it's not because they don't have questions. They tend to keep the questions to themselves. So we tend to need to ask them more, engage them more, because naturally the doctor-patient relationship in Botswana is one-sided. So we need to encourage them to be more involved. And there are a number of other things that we need to do, but I'll just mention a couple. One, since we are mostly doctors on this call, is to really promote self-management programs, cognitive behavioral therapy, and group therapies for managing depression, anxiety, and insomnia, and increase resources for access to comprehensive healthcare provision to address patient wellness, including drugs, nutrition, and rehabilitation services. I'll only mention those, but really, we do find that people are scared of patients, of kidney disease patients. They don't tend to give them the medications that they need for simple pain or peripheral neuropathy or erectile dysfunction or nausea, vomiting, depression. These are all the problems that are normally high on the list for all our patients, but the level of care, the level of treatment that the patients get in those symptoms is relatively low in Botswana. We tend to give them all other things except what they may actually be complaining of themselves. And until you address those things, patients will never be very happy. There are other things like research, changing what we study about so that we really focus on what do the patients want and ask questions around patients' centeredness. Those are the things that I really think we should try and focus on in Botswana to try and improve our patient-centeredness in our healthcare delivery. Those are really the few words that I wanted to say. Otherwise, I'm really curtain raising for the two main speakers for today, Dr. Moloi and Dr. Thembi Mosalakatane. Those are all my few words of introduction or recognizing the fact that today is World Kidney Day. All right, thank you, Doc. I think that's my presentation done.
All right, thank you so much, Dr. Saleshando, for setting us off. And a number of people on the chat function are saying they can't hear. I would kindly ask we switch off our cameras if you have them on for the bandwidthing of the internet so that people can actually hear the presentation. I think internet is a headache, so please do switch off your videos if they are on. I encourage people to also try to log on again, log off and log on. That may be a little bit better. Moving on, we now have Dr. Walter Molloy, who's going to talk to us really about the experience about COVID-19 and the kidney. Dr. Moloi is a consultant physician and nephrologist at Sekitumile, Masire, and GPH. A lot of us as participants will know that he's worked quite a number of years at Princess Marina Hospital, running the PD clinic as well as the dialysis service. He is a former lecturer, now an adjunct senior lecturer in the Department of Internal Medicine with the University of Botswana. Dr. Moloi completed his FCP from South Africa, his MMed from University of Botswana, completing his nephrology training at the University of Cape Town and Groote Hospital, as well as obtaining an MPhil at University of Cape Town. I actually see one of his great teacher and mentor on the call, which is actually quite great to see. We welcome you, Dr. Moloi.
Thank you very much, Dr. Palai, for those quite gentle introductions. It's a great pleasure that I can see Dr. Bianca Davidson and Prof. Wayne in the call as well. These are the great teachers indeed. And it's a huge pleasure for me to be speaking about the COVID experience in Botswana, especially pertaining to the kidneys, as we've been doing this since around April last year. So I just thought I should share the experience on World Kidney Day as we focus on a more patient-centric theme in the World Kidney Day, but also not to forget the plight of our patients with COVID and those on dialysis and those on PD and transplant who unfortunately ended up having COVID. So I'll go through what we've gone through so far at Sekitumile Masire with our COVID experience. So no conflict of interest in this presentation. And I think a lot has been said about COVID and the kidney. And we, just from the beginning when COVID came, and everybody knew that it will more likely affect negatively patients with multiple comorbidities, with hypertension, diabetes, obesity, and we knew that those the patients who are going to most likely affected. And that's exactly the patient population of patients with kidney disease, because almost all patients with kidney disease will have hypertension. Majority will have the diabetes. As you know, those are the commonest causes of kidney disease in the general population. And on top of that, we have the transplant population who are also immunosuppressed with the immunosuppressive therapy that we put them on after transplant. And then from the beginning, we knew that patients who are on dialysis, one of the greatest risk factors that they face is that they visit the health facility much more frequently than other patients. So they are more likely to contract the disease other than just the underlying risk factors in terms of comorbid conditions. So we thought that as we fight COVID, we needed to have some way that we can support patients on dialysis, but also cognizant of the fact that COVID affects the kidney. You can have acute kidney injury in patients with COVID through multiple mechanisms. So we thought we needed to have a renal support services in a facility managing COVID patients to ensure that if patients develop AKI, we are resourced enough to manage them. And as we are all aware, our first case of local transmission in Botswana of COVID was in March 2020. But from the beginning of the pandemic, it became clear that the kidney is not spared, and patients with chronic kidney disease are affected, and those also without primary kidney disease will likely be affected through acute kidney injury. There are multiple ways to which they presented. And the initial studies show the prevalence of AKI in this patient population to be around 5%, and it's been up to about 5 to 15%, depending on which study you look at. And there are multiple mechanisms through which this occurs. And initially, when a lot of pathological mechanisms were proposed, we looked through the direct cytopathic damage that occurs, and then there was also an immune-mediated damage that was also proposed, and also the ischemic, the iatrogenic injury, because we tend to give this patient drugs, and then sometimes the drugs can be toxic, but also the fact that we may not adequately hydrate these patients. They come in with respiratory rates of 40, saturating around 60, 70%. By the time that they come, they have significant insensible losses. And if we don't address this quickly, we may actually have a significant acute kidney injury. And the other things that we've seen are things like rhabdomyolysis in this patient population. And then we know that there's impairment in renal microvascular circulation, as we know that there is a lot of coagulopathy that we see in patients with COVID. And the other study, this was a study that was done in America, in New York, where they looked at the patients who were admitted in New York hospitals who presented to hospital and looked at through the prevalence of AKI. You can see that a lot of these patients had some degree of acute kidney injury, mainly stage 1 AKI. And they realized that actually the patients actually have a very high rate of death. The mortality rate was actually at up to about 35% of patients who develop AKI. And the risk factors were old age, Black race, hypertension, diabetes. And these are the conditions that we find. You know, our patients on dialysis are older, are relatively older. They are, our patient population here is mainly Black race, and hypertension and diabetes are very prevalent in this patient population. And then when we looked at the outcomes as well in this patient population, we realized that the overall mortality among patients who develop AKI is about 11% overall mortality. But you can see that once someone has AKI and has severe disease and requires ICU care, mortality was as high as up to about 80%. And some centers have actually seen a mortality rate of even higher, of up to close to 90 to 100% of patients who are admitted to ICU. And majority of those with AKI who require some form of renal replacement therapy did not really make it out of ICU. And coming to patients with end-stage kidney disease, one of the things that we noted was that things like increased rates, as we mentioned, mechanical ventilation, and lymphopenia and Black race were seen to be associated with poor outcomes in this patient population. And in our setup, we have not intubated or mechanically supported any patient with end-stage kidney disease based on first of all, the limitation of the resources, and also the fact that these patients have already multiple comorbidities. If they get too sick to a point where they need mechanical ventilation, the outcome in different studies have been shown to be poor. So we have not really been supporting them with mechanical ventilation other than just ensuring that we optimize non-invasive forms of ventilation. And if you look through the COVID cases in Botswana today, you can see that from the beginning, we had fewer cases, but then the cases kept rising. And now our cases up to, by March, we have passed the 30,000 mark of total COVID cases. It may seem a small number, but if you look at that in view of the population of only about 2.5 million, so it's a significant number. It's actually comparable to what you see in a lot of other densely populated nations. And this is the latest local statistics of COVID. If you remember the report from Monday by the task force, we have already to date have around 413 patients who have died with COVID-related complications. It may still look small as a number compared to what you see probably in South Africa, but if you look at this in terms of our population, it's actually a hugely significant number. And we know a number of new cases of COVID still remains significant. So we are currently at the peak of the disease. So in around March, when the pandemic started, and the main strategy for the country at controlling COVID was containment, to ensure that we prevent the spread of the disease. So the cases that were diagnosed, we were kept in a place where we make sure that they won't be able to transmit the virus. And Sekiti-Mila-Masira was chosen as a facility that was going to be a COVID center for the duration of the pandemic. We found ourselves as a country in a very peculiar and an advantaged position, whereby by the time the pandemic hit, we already had a facility which is of 150 bed capacity that was not yet functional, not yet in use. So it was actually roped in to actually take over the care of patients with COVID. So because of our concern as the Nephrology Society, through the Nephrology Society of Nephrology Society of Botswana, we motivated that support services be established at the hospital to support patients with COVID who develop AKI, and also those on chronic maintenance hemodialysis who would need to be supported or isolated while we are actually using this containment strategy. And the services that were proposed to Sekiti-Mila-Masira was to establish hemodialysis services in terms of intermittent hemodialysis and also chronic kidney replacement therapy. And this was, we saw this as important because we knew these patients are going to be critically unwell and they may not be candidates for intermittent dialysis. We may need to support them with much gentler dialysis modalities. We also went on to establish also the peritoneal dialysis services. And we knew this, that patients on PD may also end up coming into the hospital and we must be in a position to care for them. But also, we were aware that because of what we knew at the time with regard to coagulopathy we experience in patients with COVID, we knew that you may have to dialyze some patients with automated peritoneal dialysis who are in ICU that you cannot put a line on or they cannot anticoagulate. So we actually prepared for such scenarios in eventually if they were to happen. So what we set up in terms of hemodialysis in ICU, we were able to have two CRRT machines which were capable of doing plasma exchange as well. And this was around the time when a lot of therapies were still being debated, which one is beneficial. And we considered plasma exchange as one of the therapies that we will potentially use. And we set up for intermittent hemodialysis services in ICU because we are aware that not every patient in ICU will be a candidate for CRRT. And also noting that a CRRT itself as a treatment modality is a labor-intensive modality. So we need closer monitoring and longer monitoring. At the time, we're also struggling with staffing. So we don't have enough staff to staff that service. And we're only going to prescribe it when it's truly indicated. And then in the dialysis unit, which is we call it ambulatory unit, we actually ensure that we have dialysis machines specifically to support patients who are already on dialysis, who get COVID and will need to be admitted to the facility. And this happened around March, April, and May. These plans were going on. We were able to get the staff to the unit, and we didn't have a trained nephrologists at the time. So what we did is the ones that we knew they had some experience, we brought them to the facility and attached them to the Renal Care Institute, the unit for Dr. Saleshando, who was gracious to allow that they be there to actually get some hands-on experience on how to dialyze patients. So as the Nephrology Society of Botswana, we came up with an algorithm of how to actually manage patients with COVID. And that was at the beginning of the pandemic. But the plan was that all patients who test positive will be admitted to Sekiti-Mila for isolation and dialysis while they were there. Because at the time, we didn't want patients who were positive to be roaming the street. And all this preparation started early, and then by August the 18th, we had our first patient who had end-stage kidney disease and COVID being dialyzed at Sekiti-Mila-Masira. It was a gentleman who actually came in, had missed around 4 days of dialysis, came in with severe shortness of breath, and was COVID tested at the Princess Marina Hospital. The dialysis unit couldn't take him out because they were waiting for the COVID results. So he stayed in the emergency for about 24 hours while waiting for COVID results. And upon arrival, they were positive, and it was around night when he was transferred to Sekiti Masir. And that was the day that the machines were actually installed at the Sekiti Masir. This dialysis machine were installed on the 18th, and the same day we had the first patient who required dialysis. It's like everything just fitted together. And then within the same week, we had a first patient in ICU who has been in ICU for about 2 weeks, who now developed acute kidney injury. And then we had to start them on CVVHD because they were hemodynamically unstable. So we actually were fortunate that we had the resources ready for patients when they needed them at the right time. And this all, I must say, could not have happened without the support of Fresenius Medical Care, who at the time brought through their agents to come and train our team and work with our team on actually using the CRRT machine and also on dialyzing acute and chronic patients in the dialysis unit. So to date, since the first patient we saw on the 18th of August, we have actually admitted and treated 90 patients who had end-stage kidney disease and COVID. And what you will note here is that majority of these patients are men, about 62% of them are men. And almost all of them are coming from the Greater Gaborone region. And if you may know, is that majority of the dialysis centers in Botswana are in Gaborone, or in the eastern margin of the country. That's Gaborone, Palai, and Francistown. So this is where we are receiving our patients for dialysis with COVID. And majority will be coming from Renal Care Institute because they're actually sitting on Princess Marina. And there was a lot of cases that came from Marina around the same time. And as expected, a lot of comorbidities, hypertension and diabetes were very prevalent on this patient population. And I put in here the treatment with DEXA. It was important to note that initially on the first days when patients presented, they were mainly asymptomatic. And after the recovery trial came out and showed that there's a mortality benefits for dexamethasone, we have actually then started using dexamethasone for our patients who required oxygen. You can see just about a quarter of our patients required to be treated with oxygen and therefore need dexamethasone. So it shows that our majority of our patients, when they came, they were not critically unwell in the first few days. But in the later days, now we had a lot of patients who were critical, who needed to be on a dexamethasone. I'd like to also mention here that all the data that I'm going to present has to be looked at in the context of our dialysis population in the country. So to date, we have around 642 patients in the country who are on some form of renal replacement therapy. Majority of those are on hemodialysis, which is 455, and peritoneal dialysis, and then we have 35 transplant patients in Botswana. And when you look through the different modalities and the patients who tested positive for COVID or treated as Masir, we found that about 84 of our 455 hemodialysis patients in Botswana tested for COVID, were COVID positive. That's almost 20% of the hemodialysis population. And then we had only about 4 patients on PD and 2 transplant patients who tested positive for COVID. And the second transplant patient just came, is actually still in the hospital as we speak now. So now if you look at the trend of the admissions as they came in, around August, October, that's when we had it, August, September, October. If you remember, our first peak really happened around September during the independence holidays around that time. But then we had this peak where we had a lot of cases. We settled in December, but we got very busy in January with much more cases coming in. In February, the cases got a little bit better. However, the trend is misleading because there were testing issues around mid to end February, where now the testing frequency was reduced in most dialysis units. initially we were able to pick a lot of these asymptomatic cases in the different units because units had regular schedules. At least once a month, they had routine testing for all their patients for COVID. But then that was changed in a lot of facilities when some restrictions were put in place with regard to testing. And then currently you find that the cases appear to be fewer from the units because they're not testing as they used to test. But again, the other thing to note as well, that the cases seems like March, though it's still beginning of the month, we may have seemed to have admitted very few patients, but because of the strain in that we are experiencing at Masire, some dialysis units have devised ways of managing their own chronic dialysis patient. So I may say the statistics for patients with chronic kidney disease in Botswana from is as accurate as until February, wherein now there's a trend where some people are starting to manage their patients in their facilities. And we're trying to look for those patients and keep them in our record of patients who are on dialysis who tested positive for COVID. But if you were to look at the admissions as per dialysis modality and the mortalities, you can see that of the 84 patients that we admitted with hemodialysis, we lost 10 of them, and we lost only 1 patient on PD of the 4. We haven't lost a transplant patient. I'm crossing my fingers that we don't lose any. And if you look at our mortalities, it seems like the strain that we are dealing with now is much more lethal than the one that we were dealing with last year. So our mortalities rose significantly in this first quarter of this year. We had 3 deaths in January and 6 in February alone. But from August to December, we had only 1 mortality. And March is still new, we are still counting. But we hope that we don't get any more mortalities. But if you look at the cases that we managed with we had AKI. So the cases that were referred for nephrology care with AKI were only those with severe AKI. So important to know that we only have those with severe AKI. So in those patient population, majority of other patients probably stage 1, stage 2, they're probably managed by the other teams. But of all the 48 that we saw, 12 of them ultimately demised. And then if we look into mortality, total oral mortality, those in ICU, so it's actually mortality for severe AKI was around 25, but in ICU, mortality was 8 out of 12 that we managed. So I tried to compare our rates of the positivity with the other studies. So just for Botswana alone, we see about 11% of the cases of patients on hemodialysis. The total hemodialysis population sitting at 455, and we have 84 cases that are positive. We've lost about 10 of those, and that's the number of cases. That's around 11.9% mortality. If you look at the mortality of this study from US, it was also, it looked at all the patients on maintenance hemodialysis, that they had 438 patients testing positive out of almost 8,000, and 109 of these passed on. That's almost 25%. And then we look at the one from Cape Town, I think it's from UCT, Forestry Hospital, where they have 259 patients on hemodialysis. 31 of them tested positive, and then they lost 6 of those with a mortality rate of about 19.5. Obviously, these numbers are very small compared to the study that was done in America. So basically, though we have significant number of people who died, our mortality rates are not as bad as what the other people are seeing globally. So what does all this mean? So as we already know and mentioned in the beginning, that patients with chronic kidney disease and on hemodialysis, they had a higher risk of COVID-19 infection and also mortality when they get COVID. But again, the other thing is we need to really prioritize our patients for SARS-CoV-2 vaccination, because this patient population in the general population, if you compare them with the general population, they actually have a higher rate of infection and also mortality. So I need to acknowledge in here the renal team. We have a wonderful team of nurses who work with us and the doctors who work with us. and then also the management of secretary for actually listening to us and agreeing to support our cause despite the cost implications, and the Fresenius Medical Care for supporting us with human resource and training. If it wasn't for them, we wouldn't have really moved much. But most importantly, Nephrology Society of Botswana, Dr. Kavrik has been very instrumental, Dr. Saleshando, who are the leaders of the society, in actually mapping the direction of where we go in terms of managing patients with COVID and kidney disease. Thank you very much.
Thank you so much, Dr. Moloi. Great insightful talk. Thank you for giving us those numbers. They really do give a perspective, and I hope participants, wherever they are, can appreciate what we are really are dealing with. I think it's also important that people know that they have access to contacting Secretary Midamasi, especially Dr. Moloi, in cases where they are not sure about management, patients that may develop, kidney issues outside Gaborone. It's very important that these patients are followed up. At this juncture, we're going to switch gears a little bit. We are going to go to Cape Town. We have in Cape Town one of our very own. We're going to talk about little people now, the pediatric aspect of COVID-19, but in Cape Town. I welcome Dr. Tembisile Mosalakatane, who is a pediatrician and lecturer with the University of Botswana. She's currently a pediatric nephrology fellow with the University of Cape Town. And she's involved in training there. She is a member of the Nephrology Society of Botswana, Botswana Pediatric Association, the International Society of Nephrology, International Pediatric Nephrology Association, and International Pediatric Transplant Association. Dr. Mosalakatane is a big PD enthusiast. She has been involved in running the PD unit and assisting with Dr. Moloi previously in Princess Marina. We welcome you, Dr. Mosalakatane. Please go ahead and educate us.
Thank you, Dr. Palai. Can you hear me?
Yes, we can. Yes, we can.
So we're going to switch gears a little bit, and we're going to go to the little ones, because sometimes I think they're often forgotten. And it's mainly because when COVID started, over the news, we'd hear that kids really don't show signs or they don't get affected by COVID. But things have changed as days and months went by. We learned about COVID, and we know that now that we need to look at our kids when it comes to COVID-19. I'm just going to talk about the lesson that I've learned as we're managing kids with COVID-19 at Red Cross, where I'm currently training for the pediatric nephrology. So it's just basically the lessons I've learned. So before I go any further, let me just acknowledge the International Society of Nephrology and the International Pediatric Nephrology Association, as well as the African Pediatric Fellowship Programs, who have actually made it possible for me to undergo this training. And I think without them, we wouldn't have or even thought of having a pediatric nephrology in our country, because currently we have no pediatric nephrology in our country. So we have to really give thanks to these three associations. So my outline today, I'm just going to talk about COVID in our little ones, and I will go on talk about AKI. And I've also got good news to share about COVID in pediatrics, with relation to AKI. So, like I said, initially when COVID started, we would hear that kids really don't get affected by COVID. So pediatricians, we were kind of relaxed in terms of our pediatric cases, and it was because really and truly, yes, we didn't have these kids coming in for presentation. But here in South Africa, as when we, after like 1 month or 2 months post our peak, then we started seeing this weird disease that looked like Kawasaki, where kids now come in sick. And unlike Kawasaki, even though they had the similar presentation as our Kawasaki disease, these kids were quite sick when they came in. And these kids also, because they were quite sick, some of them needed ventilation, and some of them also needed peritoneal dialysis. Europe and America had seen similar cases also just few weeks after their peak, and they had already reported on this weird disease. And at that time, they call it a pediatric inflammatory multisystem syndrome associated with COVID. As you can see, this was from the US. You can see the blue ones is COVID in the adults. The red one is the kids now coming in with MISIC. You can see that it lags behind in terms of COVID. And I think today, I think we're very lucky in Botswana that the first peak, really, we didn't have any kids coming in with MISIC. But I think now, because now we're having our cases going up, as shown by Dr. Moloi, this is, we have to be really, really vigilant in picking up these kids very early, because picking them up very early, you can actually save a life. And I think this is the time, because our peak was in January, they come in a few weeks after the peak, and this is the time now we should be really looking for them. One case has already been reported at one of the private hospitals in Botswana. So this diagram just shows we have stage 1, which is the early infection. We have stage 2, which is the pulmonary stage. And then we have the delayed hyperinflammation stage, which is the stage 3. And this is where MISIC or PIMS comes in. Stage 1 and stage 2, our kids are fine. But stage 3, they get this multi-organ involvement, and it can trick you. So if the adult people think they're not gonna get patients, these patients can go up to age 21. And I know that in peds, we see cases up to age 13. So the adults really are not, should also be listening, because they will get these cases as well. Surgeons also should be listening, because many of our kids actually come in with the signs of acute abdomen, and we had few actually who have been taken to surgery thinking they were appendicitis, only to find out that it was just mesenteric adenitis or some inflammatory things going on in the bowel. So nobody will be spared from this MISIC. So while we're trying to understand MISIC now, we call it MISIC, we're moving away from PIMS. CDC came up with the case definition, and WHO has already adapted to this case definition. And like I say, age 21, fever, they get inflammatory markers that are high, they get organ involvement, they get with multi-organ involvement, and they shouldn't be really a cause for these signs. They have to have COVID now or previously COVID positive. In the early stages where we couldn't test for antibodies, would say that if you had exposure, then it will come in as a positive case, even if you never tested positive. So they also came up with the management for these kids. The main thing is fluid management. They come in with cardiogenic shock. So many of them will need anatropic support in terms of dobutamine. And coming down the inflammation, we give them steroids. Some don't really respond to steroids or IVIG. Then we'll give them IL-1 and IL-6 blockers, tocilizumab, as well as anakinra. But I know the IL blockers, we really don't have them in Botswana. But good news is that the majority of our patients do respond to IVIG and steroids. And because right now at the moment we don't have mid-roll or readily available, any steroids at this point can will do. They come in with coagulopathy, so you need to give them thrombotic prophylaxis because they get coronary involvement, coronary vessel involvement, they get aneurysm like Kawasaki, so you need to give them aspirin. Some will go on needing respiratory support and ECMO. I might say that we haven't really had majority of our cases needing a lot of respiratory support. We picked them early and we're able to save them. So this was the data that was presented by one of our colleagues here, Kate Webb, yesterday, and just talking about how South Africa has been diagnosing MISIC in all the provinces since and this is during our first peak. Right now, we just had our second peak, so we're now about to get another surge in the MISIC cases. And you can see Red Cross was leading in these cases. The good news is that few needed ICU admission and few needed ventilation and few needed dialysis. But of course, these kids will need anatropic support, and we don't have any death at the moment. So we've really managed to treat these kids and get them home to their parents. So briefly, the ones that really needed dialysis, just the 3 cases that needed dialysis, one boy who was COVID positive about half a month ago, now presented with diarrhea, vomiting, and headaches and rash. You can see non-specific symptoms, and he was not positive of COVID at that time. Elevated inflammatory markers and came in already with AKI. Echo showed LV dysfunction, and there was also coronary involvement as well. And 9-year-old as well, female, fever, abdominal pain, vomiting, also with increased inflammatory markers and impaired renal function, but it only developed on day 3 of admission, came in with normal renal function. COVID was negative at that time, but when we did the antibodies were positive, also came in with shock with low ejection fraction. The third one came in with fever, vomiting, rash, typical of COVID, but the mom was reported to be COVID positive. Similar episode as well, negative COVID, but antibodies were positive and also had impaired LV dysfunction. So I'm not going to go through the pathophysiology because Dr. Moloi has talked about it and how COVID affects our kidneys. It's similar as in adults. And these are just the cases from the US, just to show that even though we have multi-organ involvement, renal is there, but it's not as significant as we see cardiac as well as GIT. So those are the main organs that are really involved in MISIC. So our good news is that not all require renal replacement therapy. So this is good for us because not everyone have access to renal replacement therapy or know of renal replacement therapy. So when you get a patient with an AKI, the main thing just to minimize the insult, reduce the extrarenal complication and restoration of the renal function. And it's the same goal that we have with any other AKI. So our strategies in managing AKI in a MISIC patient, number one, you just have to recognize a kid who will get AKI. You do your fluid restriction and you avoid nephrotoxic drugs and renal adjustment doses. So I think we always forget about the medication that we give in our patients, and Dr. Moloi has already alluded that they are one of the risk factors for AKI. And what we do here as well, we give IVIG. So the debate is that do we start with IVIG or do we start with steroids? So I think the move now is to move on to starting steroids first and IVIG for the ones who don't respond. And this is good news for us because we don't have a lot of IVIG. For IL-1 blockers and 6, we don't have that in Botswana. But we do have anatropes like dobutamine. So if your patient is in shock, and is usually a cardiogenic shock, so the anotropics of choice will be your dobutamine. Volume is important because they come in with volume overloaded. Unlike what on the adult side, where sometimes they come dehydrated, ours come with volume overloaded from cardiogenic shock, and they get metabolic disturbances. So I'm not going to talk about metabolic disturbances, but I'll talk about volume issues because that's where we always don't manage properly. So what we do here at Red Cross is that we really do fluid restriction if we think our patients are fluid overloaded with cardiogenic shock. So you will give them insensible losses if you're not sure what the output is. And we actually do urine output and fluid adjustment every 4 to 6 hours. So you really have to be meticulous at measuring and making sure that you know what the output and making sure that the fluid management is done right. And sometimes we are afraid of doing total fluid restriction where you're not giving anything fluid-wise. And we do that in our patients, especially if they have element of pulmonary edema. For kids, unlike adults, for kids, there is a role for Lasix. So we give Lasix, and we try not to give very high boluses doses because of the ototoxicity, but we give Lasix infusion. And we might also challenge with aminophylline to use it as a diuretic to try to push their kidneys to diuresis. And I can testify to this really works for our patients. So you should always consider Lasix and aminophylline together with your fluid restriction. And if we are going to give IVIG, in our protocol, we've written that we give it 8 to 12 hours. We don't give it 8 to 12 hours because we don't want to overload them. We give it over 48 hours. That 2 milligrams per kg runs over 48 hours. And we hyperdilute it. Hyperdilution meaning that if the vial says diluted to 400, we dilute it to 200 just to cut down on the volume. The dobutamine, you hyperconcentrate it, and we monitor our patients' BP, urine output, and weight, and they have to be catheterized so that you are on top of your fluid management. And indication for dialysis is the same if you are AKI from any cause or from MISIC. So the indication for dialysis doesn't really change. But for us, because we don't have facilities to really do HD in younger ones, the best thing that I should advise is the peritoneal dialysis, because all our patients, we have done peritoneal dialysis for them. So our cases, the 10-year-old was ventilated, had coagulopathies, GIT, bleeding shock, needed anatropes, fluid overloaded, and was dialyzed for that. But the dialysis for all the 3 patients really doesn't take long. It's about 2 to 3 days. And by day 7, all these kids are back to normal. They go back with normal renal function, and they have recovered their cardiac function as well. So it's the same for all the kids. So this is a paper that my supervisor, Prof. Minon, and my other colleagues wrote on the first PD that was ever done in the world in a patient with MISIC. And it was just to try to show that we are in Africa and we have to do things that Africans can do, and PD is one of that. So the good news is that peritoneal dialysis can be done by any doctor anywhere in Botswana. And before 2016, I think we never really thought about dialysis in pediatric. I should just say thank you to the Saving Young Lives for really introducing PD in Botswana. And these are the doctors from Botswana and the nurses that have really been to our Saving Young Lives courses for PD. So we can do PD in Botswana. And insertion is at the bedside, equipment, even though I would advocate for equipment to be bought for peds. And like I said, can be done by any doctors, and we can make our home solutions. And there's a paper that I'll share that Prof. Minon and colleagues also wrote, that we can make our solution with Rhenus lactase and dextrose. And this is the PD prescription. I won't go into that, but prescription means that how much am I putting in and what type of fluid am I using, how long is it going to stay, and how long is it going to drain. So if you need the PD prescription, we can share that as well. So in conclusion, I'll say COVID-19, yes, our kids really are asymptomatic, but we should remember that post our peak, we should look for MISIC. And because MISIC, if you miss it, your patient will die because they deteriorate quite quick. And if you miss the boat, the outcome is really bad. And the good news is AKI is there, but it's very minimal patients that get it. And remember, if everything fails, peritoneal dialysis and fluid management in these kids is the key. So this is my professor, and I think this is the thing that I've always remembered. In 2016, she said, do not let any child die of AKI without trying dialysis, because PED can be done by any doctor who can do a ascetic tap in Botswana. And thank you to the picture below is the team that have been my family for the past year at Red Cross, and that is the Ministry of Health, because the Ministry of Health has been supporting kidney disease, and the other part, those are the NESBO team as well. Thank you.
Thank you so much for that wonderful talk, Dr. Mosalakatane. Thank you, I think, for giving us a perspective of pediatrics. I think it really also helps, especially for us here at Sekitumilia Masire, as well as people or other healthcare workers in the district as well. At this point, we're happy to take questions and answers. I've just been looking at the chat function. Firstly, there's a question there, and then there's one that was emailed. The first question is with MISC. Dr. Macheng is asking, are the patients infectious, and do they need isolation in COVID ICU?
All right. So remember, these kids, MISC comes towards when you are now clear of COVID. So the majority of the patients, they are not infectious, and they don't really need isolation, because they present maybe days and weeks after their COVID exposure. So most of the cases are actually, when they come to us, they are negative. I can see my senior, my supervisor, Dr. Kutse, here on the chat. I think he can also add. Dr. Kutse is one of my supervisors at Red Cross. Maybe he can just say a few words on AKI. Music. Dr. Kutse, we can't hear you.
Okay, while she's probably trying to get that sorted. Dr. Macheng, in response again, we do have a pediatric team also at Sekitumilia Masire. I think if you do get cases in Marina, please contact the pediatric team. Dr. Mulala is there. I can give advice. Dr. Kutse is not able to unmute yourself. Can I ask Rob to please unmute her?
People are free to actually unmute themselves.
Okay, thanks, Rob. You are free to unmute yourself, Dr. Kutse.
Yeah, maybe he's having challenges, but that's fine.
Yes, and she does say, yes, I agree, no isolation is needed at the time of MISC diagnosis. The next question was sent via email. I'll pose it to Dr. Moloi. And the question says, how should we prepare our facilities to care for renal patients who contract COVID-19? Very important questions, especially if you are out in the districts. Dr. Moloi?
Yes, Dr. Palai, thank you very much. And I think that's a very relevant question. It's something that as NESBO, we had a chat about myself, Dr. Saleshando, and Dr. Kavrik, wherein we were saying in the eventuality that, because now we realize that COVID is everywhere, so we can no longer, containment strategy does not really work. And then the Sekitumilia is overwhelmed. So a lot of facilities are going to have to establish their own sort of isolation centers or COVID centers, and hospitals will have to establish a management spaces for patients with COVID. So for the renal patients, one thing that we had proposed was that there needs to be decentralization of renal care of COVID. Rather than all patients coming to Seke to Masire, the dialysis units should be able to actually manage their patients. However, there are challenges that comes up when you do that. The first challenge is that our patients, especially hemodialysis population, they come to the hospital 3 times a week. Not all of them have their own transport. They have to use public transport. So when they test positive, they can't go into the combis, and some now have to walk to the hospital or to the facility where they're going to receive dialysis. So that's one of the challenges. So for this to work, we felt that we needed to engage the DHMT and see how it can actually help in transporting patients who may not have their own transport if they're going to be dialyzed as outpatients. Now, the other thing is it will be a challenge for every facility to establish its own dialysis center or unit. So at this point in time, we can function with the facilities that we have, but when someone with end-stage kidney disease is not able to go to the facility, then we need to find ways of providing transport. But also be cognizant that renal impairment in a COVID patient is a marker of increased mortality. So a patient with COVID and renal impairment in a peripheral facility and they're not getting better, I think they need to be transferred to a tertiary center, because chances are they are going to need a CPAP, which they may not have the appropriate resources to do. They may need ventilation, or they may need to be managing dialysis as a complex form of dialysis. So it's a very, very tricky thing to do. But in the existing units have actually come up with ways of actually managing this patient. So what facilities have done is they've created what we call a COVID shift. So while you dialyze all your patients during the day, maybe you have a night shift where it's just for COVID patients, just to create that environment where patients with kidney disease can still be managed in the primary facilities. I can ask Dr. Saleshando to add on to that, and Dr. Kavrik also can have a weight onto that. But that's my opinion.
Thank you, Walter. Hello?
Yes, we can hear you. We can hear you.
Yes, thank you very much for this wonderful talk for all 3 of you. And I think, Walter, you raised very valid points when it comes to chronic patients. What I think we have to keep on emphasizing is the vaccination of our chronic patients. That's something that we have to advocate for. And when we look at the cohorts of the patients with comorbidities, they come if you get the list that if you saw the list, they should be prioritized, because this cohort of patients have to remain in the group on dialysis throughout the pandemic. So they should be among the all comorbidity group of patients. They should be on the top of the list. Same like transplanted patients. I think the first lot of vaccines that we got that includes the frontliners should include our patients, especially the transplanted patients. They're really precious to us. I think one thing that we discussed as 3 of us as a group is to minimize, which rightly said, to decentralize the units and keep the patients in the smaller units. So if something happens in the smaller units, it's less damage than when it happens in the big unit. And also to minimize the transport and the movement of the patient. Patients spend a lot of time being transported from the homes or the working place to the unit. So that's also something that we have to factor. And also we know that our staff has been affected in most of the units. We had staff members that have been affected. So we have to continue education on that. And we know that the staff often is not gets a virus in the unit. They get it either in the kitchen or they get it outside. So we have to really prevent our health workers, health personnel, because dialysis nurses are very scarce. So I think those are a few things that we always have to keep in mind and continue working on our guidelines on that. I don't know whether Hahu has to add something more.
Yeah, thanks, docs. Maybe just to add that from a nephrology side, we've been blessed with a number of guidelines early on from Wuhan, and then internationally, America, Europe, and on this occasion, Africa. The African Nephrology Society also released very detailed guidelines of what to do with patients in terms of preventing COVID and also what to do when you have COVID positive patients. So a lot of us have been following those guidelines and they've really helped. Yeah, thanks.
All right. Thanks again for the speakers. Thank you for the participants. I think all the questions have been answered. Due to the interest of time, with people expected to attend other meetings, I think we should wrap up. We do encourage again to give us feedback. Please do email robert@armumak@yahoo.com to suggest topics, also to give us suggestions on how we can improve these talks. Our next webinar will be next week, Thursday, where we'll be talking about an update on research findings on guidelines. So we'll be talking about, recent research papers or findings of research papers, IL-6 tocilizumab, as well as monoclonal antibodies, and what really this says to us in Botswana. Thank you again. Have a lovely evening, everyone.